Hello, and welcome back to Your Killer Life. We are so excited to be talking to you today, and we are going to be talking about drugs. And no, this is not the Dare-mobile. This is not the this is not a throwback to the 80s or even 90s, but we are going to be talking about drugs when it comes to all of the fun stuff associated with all of the surgeries. And before I get too far into this, I'm your host, Tammey Woodford.
Griff Woodford.
Also host. And this is going to be an interesting topic. Goodness, there are a lot of different drugs that get tossed at you. And I have had, for those of you that may have missed a previous episode, with breast cancer, I had my biopsies, which were huge, and they just gave me Tylenol 4. And we'll talk about why that was just not nearly enough for 1.4 centimeters of tissue removal out of my breast with that stereotactic biopsy. Not a good night. Then I had, so that was February of 2015. In March of 2015, I had my bilateral mastectomies. In June of 2015, I had my expanders placed. And we're not going to go into that today, but we will do some episodes on reconstruction and expanders because that is a big deal and a big painful deal.
It is.
Ooh. And then in September of 2015, I had my first, was that when I had the first implants, or was that December of 2015? It's been so many. I want to say December 2015.
I think it was.
And then we had those redone in April 2016.
Yeah.
And then September 2016, I had my nipples reconstructed. And then just in April of 2019, had my implants done again because I was having some complications and went from under the muscle to over the muscle. And we'll do an entirely different episode on that because that's a big deal. And there's a lot of...
it's life-changing.
Yeah.
Frankly.
And a lot of stuff to talk about there, especially as we talk about pain, because as we walk through this process, we will talk about pain. But today we're going to talk pain mitigation and the double-edged sword of drugs.
Exactly.
So you want to kick it off? You want me to?
Well, I would start by stating to the viewers and listeners that in terms of any long-term disease diagnosis and the mitigation of those diseases, you will be prescribed a pharmacopoeia of different medications. And the reality is that it is your responsibility as the patient and, of course, the caregiver to do your best to keep detailed logs. So you talked about medical journals before on what you're being prescribed, dosages you're being prescribed, and the ideal outcome of that is so that should you have to change physicians or if something occurs within your care, that what works for you given your individual self, and then also what works in different stages or different terms of that disease, or in our case, surgeries, because they're not all created equally. And, it's just some of the escapades that we had early on is, now, of course, I wasn't there in, my current context for the original mastectomies. So that was something that you were doing more or less on your own. But after that, once the expanders started coming in and then all of the subsequent surgeries, I was, of course, part of that. And just one example of that, of why keeping your own individual logs and being quite fastidious about it, is because we knew early on the best possible combination of pain, like narcotic pain relievers or benzodiazepine pain relievers, as well as high-test NSAIDs, so non-steroidal anti-inflammatory drugs. So we had that really well dialed in with minimal amount of side effects and really positive pain control. And then something as simple as a slight change in insurance provider. Well, okay, now we can only get half of that equation. And as far as the drug cocktail, if you will, trying to supplement that ended up being nearly a year of test fire and just, in some cases, crash and burn with something just as simple as a high-strength NSAID. So being very conscious and cognizant and fastidious in your record keeping, being able to not just say the dosage and the individual, or I should say group of drugs you'll probably be prescribed, but also your personal effects of them. So potential of developing a low strength allergy or low intensity allergy, even just due to prolonged use of a specific drug, which that's something that that we ended up having to deal with, and was very confusing for a while.
Yeah, it was. So, goodness. So I think I want to back up a little bit and just talk about sort of the different. Well, I want to talk about pain for starters, because if you're listening to this and you're a caregiver, it is, I think, often misunderstood the amount of pain that comes with this process. And I think that two of the biggest misconceptions, and I'm going to say from the guy's side, would be that you end up with Victoria's Secret boobs at the end of this, and that it's like an augmentation. And if you do research on augmentation, no, it is nothing like augmentation. And not that that doesn't have its own pain and whatever that comes with that, but this is nothing like that. So one, that is not what that's like. And two, I was not subtle when I said a few episodes ago, episode 7, I think it was, that this is an amputation.
Yes.
And with that comes a whole bunch of weirdness, from ghost nipples because your nerves are gone and your body's confused, to the pain of your nerves trying to regenerate, to just the pain of all the trauma that has happened. And so I did say, and it's true, that like you're numb to sensation, but that's the skin. That's that. And you actually described that really well. There was what'd you call the muscle sensation versus is it dumb nerves versus?
Oh, right. External sensory nerves versus internal less sensory nerves. So smart nerves, dumb nerves.
So those smart nerves all severed, confused, don't know what's going on. The muscle nerves that provided like this weird burning, tingling, like your foot's asleep. And then of course, just random ghost pain of not having the breasts anymore, and all of a sudden having that happen. And all throughout this process, and like I said, we'll talk about reconstruction later, there's a whole bunch of stuff going on with your muscles, with your body, which, you said in a previous episode, you talked about how it's even if it's a sterile knife fight, it's still a knife fight. Your body is,
right.
Yeah, you've been hit by a Mack truck, you've got some healing to do. So there is a ton of pain that comes with it. So post-operatively, and for me, because we're so far away from Seattle, I always had an overnight, and not everybody has an overnight. And so as soon as I was out of recovery and into my room, then I had whatever was the post-op drug of choice of my surgeon. And initially, and I have an amazing surgeon, by the way. Oh my goodness.
Yes,
yeah.
She absolutely is.
Absolutely fantastic. But back to the drugs, the first part of that, the first few surgeries, when I came out, it was morphine. And morphine, I would have a morphine pump. And so every 7 minutes or something, or 8 minutes, I would hit the button and then I would have relief. And we found that my body processed it so fast.
Yes. So with morphine in particular, it is, well, I would say more rapidly metabolized than something like a Dilaudid or even a benzodiazepine based pain reliever. So it's very commonly prescribed, or at least has been. But again, because of its long-term ineffectiveness, because it can be very effective in the short term, but having a long-lasting, intravenous narcotic, it's really not great for, again, that long-term pain relief. So, with your example of that is effectively maxing out the timeout feature on your morphine pump, and was still not effective. Then when we made that, I shouldn't say when the attending doctor realized that was a problem, changing that prescription to actually the same milligram dose of Dilaudid, that was a huge difference.
Yeah, I just slept, which was nice.
Right. Which, I mean, thinking about in terms of recovery, the more that you can sleep and sleep peacefully, the faster the physiological recovery is going to going to occur.
Right. And I know with me, the morphine, with all of these, to your point, knowing the side effects is really important because it's not just the pain meds. There were also the NSAIDs and there were also muscle relaxers. And so it was, this is why we called it the Elvis Presley repair kit, because it was just
Right.
this bag of whatever. And, trying to find that combination that really worked. But I think one of the more important things I wanted to talk about today was the mental health when it comes to the side effects of all of this.
Yeah, absolutely. And I would say with certainty as a caregiver, so understanding that any patient that you are in consistent and severe at times physical pain, we as caregivers, we certainly understand that factor is something we can see, something we can dialogue, and something that we have at least a somewhat known path of how to fix. If you have a pain attack, okay, well then you get another one of X and another one of X, and that should bring you back to a manageable level. Now what I personally had the most difficulty with, and the observed experience of other caregivers who really didn't know where to begin in terms of that, is the psychological side effects and the emotional side effects of long-term high-test narcotics, benzodiazepines, cyclobenzaprines. It is. I don't know if confusing is the right word, but really not going into it with a full conceptual understanding of what can happen when on those long-term dosages and relatively high dosages. Not surprisingly, about aside from the NSAIDs, every muscle relaxer, every tranquilizer, every narcotic, every synthetic narcotic that was prescribed, one of the main side effects is depression. And on all of them, when at one point we had 4 different medications on board that we were dosing daily, that one of their main side effects was depression. Right. So oddly, that happened, and to a degree that frankly was frightening. And as a caregiver, I couldn't figure out where it was coming from. And it was also, I don't know if interesting. Well, additionally confusing, because the trend was, at least in my mind, is that those significant and dark places of depression would usually come after some sort of incremental gain, whether it's surgical or in the healing process. There would be, in my mind as a caregiver, there'd be something to be kind of happy about. We've passed a milestone. We've getting closer to a milestone, where in reality, within a relatively small amount of time of those instances, was this very dark and frightening depression that would just seemingly come out of nowhere. Again, I think, well, I know that in the beginning, neither of us were really understanding where it was coming from, and that was frightening. Particularly just not knowing where to even begin. So going deeper into research and trying to understand, is this a chemical response? Is this a physiological response? And finding out that, well, 80% of the medications that you're currently on all have within the top 3 bulleted side effects of depression. So again, it's not just the physical side effects, the central nervous system depressant type thing that needs to be addressed and known. Also the psychological and emotional effects. And with that is knowing how to combat those side effects. What are some things that you can put in place, whether it's through activity, through, any process that's going to help mitigate those, almost certain side effects.
And I have been accused my whole life of being perpetually optimistic, right? Like my nickname has been Sunshine and Pollyanna.
Right.
Yeah. So for me to be in these dark places was uncharted territory, and it was so dark. And typically, your pharmacist is your friend. But this is where it gets a little bit different, because you come out of surgery and you're not the one talking to the pharmacist. Usually your caregiver or someone has gone and picked up the drugs for you.
Right.
And so you're home. And yes, you have the package insert to read. And I'm sure that I read them. And I'm sure that I don't remember reading them.
Of which you have no recollection.
Exactly.
Right?
So let's just be real there. So this is one of those things that I kind of learned as I went along that I needed to do a little more research with. And for me personally, the muscle relaxer was probably the hardest on my system mentally.
Yeah.
And it's not just mentally. I mean, when you're looking at the side effects, almost all of these, also the other side effect is constipation. So, welcome to real talk about breast cancer, because that is also a challenge that is not a fun one. And you want to talk about being incredibly vulnerable in a vulnerable space and having to, you had said on a previous episode, there's no more secrets after,
right.
after something like this. How true that is.
Indeed.
But your pharmacist is your friend. I do want to say that. It's still, as amazing as my doctors have been, there still was not a lot of conversation around the side effects of the pharmaceuticals outside of the things that would be sort of urgent or emergent.
The immediate risks to health, the physiological health, again, like a central nervous system depressant, rapid heartbeat, temporary blindness, dying, what have you. But in all seriousness, that is one thing that, in both cases, were glossed over, and that was my job for months of having direct and accurate conversations with a pharmacist at the window while you are in surgery recovering. I need to know exactly what to look for. I need to know everything I need to know about it. And whereas it was, I won't say glossed over, but the impact was certainly understated with every pharmacist that I spoke to, or any pharmacist aide that I spoke to. It wasn't through actually living through it and trying really urgently to figure out what exactly was going wrong that, I was just able to even find the information and then make those correlations.
Yeah. It was, oh goodness. It's just so interesting, that whole process. I mean, we've joked about things that I have said to you I have no recollection of. Like, apparently right. I have a preference for non-pink Barbies. That is something.
Yeah.
I made that very clear.
Yep. Completely asleep. Absolutely unconscious, and a full conversation about how you will not stand for me to buy you the pink Barbie. You wanted the blue one.
Right. Is there a blue one? I don't even know.
And you are asleep. You are genuinely asleep. You are unconscious, and we are having this conversation.
Full conversation. Right. Lovely. Thank you for not recording any of that.
You are welcome.
Yes. So, but I think that, I do want to get back to the depression, because this is a tough one. Typically, post-operatively, you're really only on these things for a couple of weeks. It was during the expansion phase that I was on them for an extended period of time. Yeah. And during expansion, they place and I'll go into deeper depths of this in another episode, but in a nutshell, they place this very, very hard implant underneath your pectoral muscle, and every couple weeks they add saline to it and they expand it. And as they do that, they're stretching your pec muscle. And as they stretch your pec muscle, that impacts your neck muscles, your shoulder muscles.
Everything.
Oh my gosh, so much pain. And then I also had a lot of pain after I had fat transfers.
Yes.
Yeah.
That was, aside from the actual mastectomies, that was easily the most violent procedure that you went through.
Oh, yeah, definitely.
The amount of edema and retained fluid, just the swelling that all settled around your pelvis. Just where it stayed was... frankly shocking.
Yeah.
That was one of the things physiologically I was not prepared for. I'd never seen that before.
Yeah. So we will definitely have some episodes on that, because those were some eye-opening moments. But typically it is just for a couple weeks post-operatively that you have those pills. I don't like taking them. so you were really more of an advocate. I'm like, just
Yes.
give me not Tylenol, because oh my goodness, just give me an Advil, give me an Aleve, give me an Excedrin, I don't really want to take these things. But you were very much an advocate for it. And I mentioned on a previous episode that I would have so much pain that I was adapting to and just pushing through, because I didn't want to take these at work because I was still trying to work. I was driving myself to work, right? So all of this stuff, you just kind of suffer through the pain, as painful as it is. And those 3 months of expanders were absolutely the worst, because I was on pain meds because it was so painful. And I was on muscle relaxers because my muscles were fighting the expansion, causing even more pain.
At all times.
Right. And that double dose really threw me into the darkest of the darknesses, I think.
Certainly. I would attest to that. To me, not just as a caregiver, but just as a partner, those were the most difficult times for me, as far as actually questioning whether or not this is going to even work, as it was so, not just the darkness. I understand darkness. I get that. But not being able to see any correlation to what was happening, like in my view of the world, and what I'm experiencing with you, having no idea where this is coming from and not having any clue of what to do. You've always been, at least since I've known you, always very optimistic and very logical and rational. And the side effects of that combination of drugs for that period of time completely took that away.
Yeah.
It was the exact opposite, on not a daily basis, but with enough frequency to where, again, just not having any clue where this is going and why it's even happening.
I think that it would actually be worse that it isn't daily, because then you're just getting hit with it by surprise as a caregiver. And so you're used to, and we are still getting to know each other also. So remember that,
There's that too.
As we go through this process, we had been friends. So we knew each other, from that aspect. And then, kind of jumping into being a little bit more and being supportive and figuring all of that stuff out and stepping into the caregiver role. But to have someone that there's no way I could have been a consistent me. All of the mental trauma of loss and fear and frustration and the lack of confidence. I mean, just everything being annihilated, stepping out of my career, just that whole loss of hope, and all of the heaviness around that will take even the most optimistic person to an area of how many silver linings can I look for in this cloud of crap, right? And then add to that the drugs, and then add to that, you're going through the reconstruction process, and you are not being reconstructed into anything that you looked like before. And especially at that point.
Right.
So there's depression around that. And so it just seemed like there was so much pain. And then I would think from your side, just like you said, you with the expanders replaced, this should be a good thing. And then in my head, I've got, the drugs that are playing. And then I've also got but I still look like crap. And I don't see how this is ever going to look like how I looked before.
Mm-hmm. Yeah, and I certainly could understand the feeling of like disfigurement, and we talked about that, specifically about that before. It was the term that you used. I certainly in that moment understood that, and in future context as well. Which we had a lot of conversations about that. And mainly, like when we were in the middle of it, is that, honey, we're not done.
Yeah.
We're not done. This is something that you and I have to be very patient in, as this is not where it stops. But each additional step forward requires a lot of time in between. I know that we all want it to happen right now. That would be certainly the most pleasant, but that's not how this is going to work. You went through a catastrophically large surgery that has altered so many things. And I think that, I don't think we will be talking about the the differences between subpectoral and extrapectoral implants, which, a little bit of a spoiler alert, as someone who has been in the medical profession before, I genuinely don't understand how that is still a practice. How you can ethically.
No, there are uses for it.
Yeah.
Yeah, there are, because you have to keep in mind, like, I didn't have radiation damage. I didn't have,
That's true.
right? My inframammary fold on one side was damaged from the mastectomies, and that was originally why, because we didn't know if my skin would hold. And
yeah, I remember that.
Yeah, so there are times for it. But I will also say that back when I had mine done, it also wasn't done very often. And so that was
true.
Yeah, that was
true.
Also a reason. So, but oh my goodness, that's going to be an eye opener for anybody on the caregiving side.
Yeah, that's a very in-depth conversation and dialogue about the unrepentant difficulties that particular procedure presents. And of course, there's many, many others that are associated with long-term disease. And it really in the same categories. They're not done very often. When they are done, they're relatively special cases. So the experience may be unique to this context, but there is a lot of applicability or application for the side effects, not just the physical, of course, the constant and consistent high level of physical pain, but also the subsequent issues and side effects that come up from just dealing with that pain.
Yeah.
And also not just the pharmacological aspect, but the psychological aspect of just being in pain all the time. There's only so much medication you can take before you endanger yourself.
Right.
And so having to stay in that ground at 24 hours a day to where nothing feels good. There is no complete relief for months at a time. Yeah. It is just absolutely draining. And again, as a caretaker who has seen the ravages of long-term disease before you and I even met, and then of course being romantically involved with you as I am with you. I am here. It's a lot more personal than just a simple caretaker role, and seeing the collateral damage from that, it was certainly easier for me to understand where a lot of the depression came from, some of the darkness, but again with the gravity of that and the inconsistency of that as well was very, very difficult for me to even just conceptualize. And again, there's nothing about that was your fault, or and the same thing with anyone going through that. They are not to blame, period. That is not how that's not how that goes. And the reason that we're even bringing it up is for both parties to understand that there are significant hurdles that you have to attack as a unit, not as individuals. I mean, of course, there's individual responsibility, but this has to be approached as a team, and both people have to be on their game as much as they possibly can be, or it will rapidly spiral out of control.
And this, I will be very frank, this is a very vulnerable episode for me because I don't remember so much of it. And the reality of it is that, frankly, it was a shift these drugs caused a shift in my natural personality.
Yeah.
And so for Griff to say, you're not always rational, which, by the way, is much nicer than you're being irrational.
Right.
Just side note. You're not always rational or having the ability to use your words to reframe conversation. It is more work on the side of the caregiver.
Certainly.
And it is fatiguing. And so here's the other thing. There's a certain amount of grace the first time someone's going through it. And then you get to the second surgery. And then you get to the third surgery. And it is this roller coaster where you're like, you go through all of this stuff and you're a little bit irrational and you're on these pain meds. And then you're like leveling out. And then all of a sudden you have another procedure and you're going through all of this stuff. And and it is just this up and down that as a caregiver has got to be, frankly, a little bit of hell, because you've got the love for this person. You want to see this person. You want to help this person. You want to heal this person. And from my side, you guys, I am sure I said things that were not nice, if not downright unkind and perfectly irrational, like jumping your butt. I think you mentioned that I jumped your butt about coasters.
Yes.
Yeah.
For sure.
Right. Okay. So do not remember that conversation at all. And you can tell that whatever I did or said or how I did it had an impact. I'm sorry for that, by the way.
That's okay.
Sorry.
Well, and again, to me, that apology isn't necessary because I know the baseline you.
But you thought, would you say that going through especially those 2 years where it was surgery every 3 to 6 months, that you really questioned if you knew the baseline me?
I was what was concerning is I did know the baseline you. What was the concern is that is not the baseline you any longer.
Mm. Yeah.
That was the real concern. Fortunately, that did not last very long. And I would say the reason why is because I was very, very attentive, particularly in those times where I don't really know. I mean, is this going to be even feasible? Is being very, very attentive to you, and not just in the physical sense, but also the emotional and psychological sense. What are you displaying to me on a consistent basis as to what will happen periodically? As explosive as it had been a couple times, that is not actually the norm. So now we have to go outside of that and find the actual causation. But to your question, yes, it is exhausting. And we've talked about that in the other caregiver episode, is that, the caregivers really need care too.
Yes.
And there is a distinct balance between being a caregiver and being a savior. They are not necessarily ones that go in hand.
Right.
Caregiving is results through patience. Being a savior is results through something grand. And you're probably not going to get something grand out of a long-term disease as a caregiver. That grand gesture of salvation, that's probably not how that's going to work. I would say the biggest benefit that I have, or the best tool that I had for being a caregiver, is patience and the ability to practice patience. And that applied to everything, the physiological aspect, the psychological, emotional, and my own as well, is because something may be very wrong today. If I am patient and I'm kind and I'm graceful, it will probably not be wrong forever.
And forgiving. You are very forgiving, because there are times that, I frankly do not remember them. And I know that I have hurt you, and and you've said that you've not relived it and rubbed my nose in it, made me feel bad for it.
No, I don't do that.
Mm-mm. And that's important too. But you have let me know that, yeah, there were hurtful times, but you did not hang on to those and make that a huge part of our history. You let other things overshadow those uncomfortable or even painful moments.
Right. And one of our last podcasts is the whole reason why I stepped up to be that person with you in the first place, is because I know how to suffer. And a lot of that comes from psychological counseling and alcohol rehabilitation, addiction, just in general. That was something that was took almost 2 decades of my life away, and a lot of things with it. And in those moments in particular where it felt like a direct attack, even though I know it wasn't, but in the moment, it's a direct attack. You don't have the ability to disassociate that. But a really sharp guy once told me in relation to things like that is that hurting people hurt people. And in the context it was said, it was addict behavior. Addicts are hurting. That's it. That's why they're addicts. They're in tremendous pain. They're trying to nullify or eradicate that pain. And because they are hurting, their actions, their words as an addict hurt others. You were in terrible pain all the time. Physical, psychological, emotional pain all the time. So having been in similar positions myself, whether all at the same time or in different parts of my life, I do know that there are often times where rationality and kindness cannot exist, because in your own internal space, it is so painful. Things hurt so much that the ability to even perceive others is nearly impossible. So hurting people hurt people.
So powerful and so true. So, goodness, a segue after that. That was so powerful. The pharmacist is your friend.
Yes, provided you know how to talk to him.
Open dialogue with the pharmacist. Right. Something that you really had to convince me to do, but was really important, is to take your meds. Okay. Full disclosure, still an issue.
So, funny story about this. I'm going to interrupt very briefly and this does involve the caretaker aspect. And I would actually say this is useful because making executive decisions as a caretaker, right, is because I know you and you've literally spat pills out.
I do not remember that.
That's a thing that happened. The first 4 days of your recovery after a surgery, not the expanders, but an actual surgery, whatever that was, I would make sure you were receiving the max dose at as close an interval as you possibly could. Now, don't just give people a big handful of pills. I am a former medical professional. I understand the concept of milligrams per kilogram, how to dose that based on time and metabolism and all the things that you need to know about that. But to make sure that you had enough of that pain control where you could just sleep. Just sleep. You would not have done that by yourself. In fact, you don't do that by yourself.
I refer to that as just tranking me out to get me out of his hair.
So I can go fly fish, right?
Right. Because who knows what happened.
Yeah.
But no, I won't. And I didn't. And I don't like the feeling. I don't like the fuzziness in my head. I don't get any of the fun side effects that people talk about and promise with any of these meds.
Yeah, not really. You don't.
No, I don't. So I get constipation and I get sleepy and I get a fuzzy brain. So, that's like, and as a type A personality, you don't like a fuzzy brain.
That's the worst. Yeah. Yes, absolutely right.
Absolute worst. So that being said, still got to take your meds, because without the rest, and I may have mentioned this on a previous podcast, I don't remember at this point, but just that, I think I did. Me coming home from work and being in a ton of pain and you saying, take your meds, and me fighting you on it and saying, no, I'm fine. And him saying, no, seriously. And finally I acquiesce. And, 30 minutes later, like I felt my face relax, that I had that much pain. Mm-hmm. And you guys, for those of you that have friends that are going through this, there are different ways that we deal with pain. You have to understand, and all of us are different. And I had never, ever in my life experienced chronic pain. Experiencing it you will do anything to try and take your mind off of it. Whether that is just mindlessly scrolling on your phone because you're focused on the action of scrolling and whatever, instead of focusing on the pain that you cannot escape and is so exhausting. And the only way I can explain it is it's just like having every muscle in your body at the same time, just, it's awful.
So I would suppose that would be a caretaker responsibility. Again, the more that you can educate yourself about every aspect of this, the better you're going to be at your job, and the better everything is going to go. The patient's job is to heal. Your job is to facilitate that, and not just the physical stuff, every other part of what it takes to be a human being. Maslow's hierarchy, you're responsible in part for that as well. One of our breakthroughs for your psychological health, and which translates into your physical health, was I bought you a stuffed monkey and a coloring book.
That's true. That's true.
And the coloring book thing really stuck.
Yep.
So what you were saying, to your point about finding some sort of mechanism that doesn't harm you in the process to take your mind off of what you are physically and in many cases emotionally and psychologically experiencing, that was paramount to healing, to getting out of that space.
So was getting outside. I mean, we were hiking and kayaking and,
yes,
so always having activities, doing things that would take the mind, give the mind other food besides just experiencing that pain. And that was work.
Exactly.
I just threw in some tips here. So the first one was the pharmacist is your friend and have those conversations. I would add to that and read your package inserts or have your caregiver read the package inserts. Pay attention to those. Mm-hmm. Take your meds, because that is actually important. I would add to taking your meds, I would add as a number 3, be a good patient. Being a good patient is taking your meds, but it's also communicating with your provider. Absolutely right.
Absolutely right. I remember the very first time we had that discussion was you were in a considerable pain attack and were unable to sleep, and we thought something was going wrong with the one of the drains. This was, of course, early on, and I was insistent that you actually text your surgeon. And that is part of being a good patient. Now, pestering or being an asshole to your providers, that is not. But openly communicating about the work that person did to that person is critical. That is part of your responsibility as a patient and part of your responsibility to enforce that as a caregiver. The reality is, when we started doing that, we learned by direct communication ways to make you just, if nothing else, a lot more comfortable,
right?
And undoubtedly sped that process along.
Yeah. And I want to say that I think a lot of times as women, like, we don't want to bother anyone.
Right.
It's fine. It can wait until morning. I'm not a priority. The rest of the world is. And maybe, hopefully not for all women. And, I'm 49 this month. And so I will say that there's a generational sort of upbringing where, not always putting other people first. And it took some convincing, but you did break through with logic that is being a good patient, letting your doctor know before something becomes a big deal.
Right.
Is really important. And I would also add to being a good patient, I would add your doctor needs to also be a good doctor. And if you have a doctor that is not meeting your needs, then please go back and listen to my episode on self-advocacy.
Yes. Because
you need to advocate for yourself and make sure that you are getting the care that you need.
Which on the advocacy aspect, it is both parties' responsibility. And to understand from the caregiver aspect is it's very common not to know when to speak up or when to shut up. So that is a conversation that you guys need to have individually. And that's the thing too, is just because, and you in particular were very, very knowledgeable and very, very precise in your requirements to your providers. Certainly times where I didn't feel like I even needed to speak because you had it down. That is not going to be the case for everybody else. You've done podcasts about how much work you invested, how much time and effort you invested into knowing exactly what your disease, your diagnosis, your treatment plan was. And you were insistent upon getting the best possible one for your exact case. That is both parties' responsibilities. That is the patient's responsibility, and that is the caretaker's responsibility to help facilitate that in any context, or as many contexts as one can. Ultimately, it is the patient's decision on what their standard of care is. As a caretaker, help facilitate those decisions as best as you are allowed by law. Put it that way.
And I think the last tip I would add is that it's okay to ask for more help or for outside help. Mental health is a big part of this. Mm-hmm. And it's okay to ask for whether it's counseling help, whether it's medication. It's okay to ask for help. What's not okay is falling into that abyss and losing your life in that regard, losing your joy, and really sitting for too long in the darkness without a way back towards the light of your life.
Yes. And something to be aware of as a patient who has a caregiving relationship. Your well-being has a distinct impact on that caregiver's life, whether you want it to or not, whether you choose to accept that or not. Yes, you are the one that's going through the disease in particular, but so is that other person. And I can say, at least in my case, and I am generalizing, but the humanistic rationality behind that of investing a lot of, even in some cases, identity in the person going through the disease and how well you are able to facilitate, care for, love, and just help that person. So when you, as the patient, when you feel yourself beginning to fail psychologically or physiologically, it is your job to communicate that. You have to do that, because if you do fail, then the caregiver also fails. Whether that's the actual case or not, that is how it is perceived, and that is devastating.
And you did a great episode on caregiving, and you and I mentioned it just briefly in a previous episode together. As the caregiver, if you need help.
That's a big part of it. Remember, it was about a year and change, about a year and a half into it for me, and I realized I was really hitting significant walls. Like I felt, because we've been doing the same cycle so much, there were things that I was beginning to resent, and being able to just be aware of that and say, wait a minute, this isn't what I'm actually feeling. This is not what my feeling towards you are. I need to start at least attempting some self-care and talking to people who, which I would say ultimately that is kind of the thing, is we are verbal processors. We are social creatures. Finding that person or people that you can even just vent to, just have someone listen to you in confidence, goes a very long ways in self-care. Because that's the thing, if the caregiver fails, the patient often fails, and nobody wins. So it is equal responsibility of self-care, self-advocacy, and caring for each other as well. I know there were certainly times where you were just unable to, kind of pull me aside or out of my apex of vision and say, hey, you're not you're not completely on. But there were times that you did, and they were absolutely necessary.
Yeah. A real team effort.
Yes.
And I think that that's the other, and not necessarily drug related, but I will say that whether it's counseling or whatever it is for the caregiver, or reaching out, finding groups, whatever it is, that there's the very real depression, anxiety, frustration, overwhelm,
Yes.
all of that stuff that also hits the caregiver. So, but back to drugs. Pharmacist is your friend. Take your meds. Be a good patient. It's okay to ask for help. Is there any? Oh, and always logs are really important. Take things as prescribed. And anything else we would want to add to that as we wrap up?
I don't think so. I think we actually covered quite a bit.
I think we did too. A little bit of extra stuff, maybe.
Right.
So yeah. So I don't miss the drugs. I'm not gonna lie.
No.
So, I guess until next time, for me in the OR, whenever that next time is. But yeah, we'll just stick with the nice Aleve and Advil and
that works for me.
Over the counter good stuff for right now. So thank you all so much for joining us on the podcast. We are so excited to have you here. And goodness, please feel free to share this with anyone who's going through any of this. If anything resonated with you, please drop us a note. We would love to hear from you because that just helps us keep going. And gosh, I guess until next time,
I would like to add, actually, so if anyone would like to drop something in the comments or talk to us directly about how to find the right counselor, how to elicit the right counseling and therapy help, we both have a pretty good handle on that just through experience and research alone. So if that is something, whether it's pertaining to long-term illness or not, the processes and the goals are certainly applicable. So please let us know if it's something that you're interested in.
I love it. Reach out. We'd love to hear from you. All right. Until next time. Keep
Thanks,
building.
guys.
Yeah. Keep building your killer life. Bye.